Good morning, everybody. We have a full session today of 7 speakers, 6 sessions. So we want to start in time. Each speaker has a period of 15 minutes. They will speak around about 10 to 12 minutes, and then you can ask your questions. And we really want to encourage you to also put your questions in the app, because also people are joining us virtually. They can also ask us questions, and you can rate each other's questions, so then we know which questions are most important for the audience, and those questions will be asked to the speakers. This session is about better mental health and support services. And the first speaker is Peter Dierinck. He works at Psyche, or Psyche, in Belgium. He's a psychologist, and he's going to tell us about quartermaking, of Quartermaking. And I think it's a very interesting session, which is going to start. And so please, if you have any questions, put them in the app. Thank you.
Hello, welcome everybody. I want to apologize for not speaking too good English. I'm not used to it, but I'm going to try. As you can see, I work in a psychiatric center, Ghent Steven in Belgium, on a ward, a bit special ward, because 95% of the people there have mental problems and are homeless. So they have lost everything in their life, family, a roof above them, work, social environment. They lost almost everything. So it was, for us, it is still for us not easy to find solutions to get them back to society. And because of, through this work, we discovered what quartermaking, it's a term by Doortje Kal, who's a Dutch lady and lives in Amsterdam, what quartermaking can do for us to get these people back to society. I worked for 2 years in a FACT team too, in a mobile team, and now I'm working in Psyche on a project quartermaking for the Flemish government. For me, community mental health is close to deinstitutionalization. There are 2 concepts very important for me, that's recovery and, of course, quartermaking. Yesterday was talk about paradigm shifts. I want to introduce, for me, 2 important paradigm shifts, and that's the different perspective in medical care, and that's a perspective from patient to civilian. That's all about recovery, about civil rights, about human rights for people who live in, who are in mental health. And the second paradigm shift is the professional working in mental health is prepared to make changes in the community. We are not used to do this. We are used to listen to people, to help people, but quartermaking is all about changing the environment so that people have can go there back to this place they want to go, to society. So it's about changing environment. Quartermaking is a military term, kwartiermaken in Dutch, and it means they are forerunners. So a small part of the army goes to the place where the army has to go later. The forerunners provide a safe space for the army, so mental health quartermakings are forerunners in society to prepare safe spaces for people with mental health problems. This is the definition from Doortje Kal. The pursuit of social inclusion of people with mental illness confronts the hosting society with contradiction and friction. In order to support integration that does not lead to unilateral assimilation, it is necessary to make room for the other, while accepting that the other remains strange and therefore difficult to some extent. So it's not about difficulties, getting away, solving difficulties. It's about giving difficulties, about friction, giving it a place so we can handle it together. These are some concepts: marveling, perplexity, fascination, hospitality, restoring reciprocity, a very important one. People giving back a place so that they can mean something for society again. And the possibility to present the unknown suffering, that's what quartermakings do. They try to explain what the suffering is about, not by medical diagnosis, but by telling the story of people or interpreting the story so that other people can understand. Connecting with organizations outside mental health. Steven will talk about the city of Ghent, where they are doing this. I want to tell something. I had to choose between different projects. I want to tell something about our project in Sledingen, a psychiatric institution, about quartermaking. We had this magazine that was called Kiosk, and it existed from 1994 to 2006. It started on a ward. It was 2 monthly, so it was a magazine that was made to explain to the citizens around us in Sledingen what is mental suffering, what is living in an institution about. And then in 2004, sorry, but it's in Dutch. It's a paper it's from paper. There's an ex-patient shot 2 citizens nearby our institution. So that's people bringing flowers on the place where the people were shot. And then there was the first meeting with the people from Sledingen, and they asked for more control, being more severe. So we had this first moment, we had to listen a lot and to contain the emotions and try to understand what was happening in the society there of Sledingen. And then our director from the institution organized a hotline and a meeting with the neighbors. It was a structural way to deal with the people in Sledingen. So there is a phone number. People in the surroundings of the institution can call us, and we are going there and try to help and try to see what's going on, what's happening, what problems are. There is a meeting every 3 months where all these things that came in, we try to explain what we did. So we try to be very transparent what happens between the institution and the neighborhood. So this is the explanation about this hotline. So this meeting is quarterly. The mayor is there often, the local police officer is there, our general director, Jochen, who sits here, is there. And we're talking about the activities also we organize. We organize a lot in the neighborhood now. So we did a garden party, a meeting with the neighbors, cleaning the garbage in the neighborhood. This is all working patients, caregivers, and people from Sledingen working together, doing all these things. We had a reward for our work. So in 2016, we developed we were talking about how this place could be integrated. So it's now a place of, we work together to make this place as patients, civilians, caregivers work together to create this place. This is the opening. In the middle, you can see some of the relatives, the brother of the woman who died there, and who opens this place together with us. So now we are meeting every Thursday, coming together, singing, reading poetry, drinking coffee, just relaxed. And we are really part now of this neighborhood. This place is really a part of the neighborhood, and we are very integrated in the neighborhood. We know a lot of people. And next Sunday, for instance, there is a procession because it's the 800th anniversary of Sledingen, and we're going in this procession, and we're going with T-shirts from Kwartiertje, that's the name of the place. So again, patients, caregivers, and civilians together, the same T-shirt, and we have a lot of symbols about civil rights for people with mental health problems, like, I don't know if you know Marco Cavallo, from Franco Basali and Trieste. We carry a little horse because that's the symbol for the civil rights. Okay, that's what I wanted to say. If you want to read more, I have this book. It's for the Dutch people. It's a translation from Hoopverlenen. It's by Routledge, and all these things about quartermaking are in there. This is very interesting. I think it's an art project, but also a social project by Ronald Raal, border wall architecture. So you can see it's the border between Mexico and the United States, and he made there a connection from people from both borders are connecting. And that's, for me, this is what Quartermaking is all about. Is you use barriers and you lift those barriers and you do something together, even with a barrier like this. So connection is what it's all about, connection between people with mental health and civilians. Thank you.
Thank you very much. Any questions from the room for this speaker? And no questions from the virtual audience yet, but we have one now in the room. Yes? Yes, I wondered... Wait, just wait for the microphone. Yeah.
I wondered, professionals working with in your organization, how did they experience these, maybe extra activities they had to employ?
Oh, they changed their activities. We have a person who is sport, CREA, Ergo, and all these things are about connection. So the sport is walking with dogs, and people from the neighborhood have dogs, and patients go along with the dogs, and so it's all about, all these activities now are all about connection.
It's about building bridges.
Building bridges,
Yeah,
yes,
yeah.
yes. Doing things together with people from outside mental health.
Yeah.
Can I ask one question? What challenges did you face with the creation of the project?
The challenges now, for instance, are that young people from Sledingen or from other places are taking this place and don't handle it very well with respect. So we're trying to integrate this new group now. So we are a group from people from the hospital, civilians, and other groups now are doing things we don't understand, and we try to integrate them now together. So it's a process that goes on and on and on, I think. It never stops.
Okay, thank you very much.
Somebody is asking to show the title of your book again.
Ah, okay.
On the previous slide. And in the meanwhile, I would already like to welcome your colleague, Steven Gillis, who's also going to talk about a project which is near to this project, about the neighborhood approach as a leverage for municipal integrated mental health care. So if you have any more questions for the previous speaker, you can still put them in the app, but I think you're going to build further on the previous presenter.
Can we move to the other presentation, please? Yeah. Okay. Okay, good morning, everybody. My name is Steven Gillis, and I want to thank Peter for introducing Quartermaking in 15 minutes. I wouldn't be able to do that, so thanks for that job. I work for the city of Ghent for the health department. Ghent is a city in Flanders with about 300,000 inhabitants, of which are 40,000 students. So it's a medium-sized medieval city. In Ghent, as in Flanders, psychological problems are very common. 33% of the Flemish people report experiencing problems such as anxiety, stress, depressive feelings. 15% have mental disorders, and 1 to 2% have severe psychiatric problems. However, only half of the people find their way to the right care, so half of the people don't find the right care to support them. We also noticed that in Ghent, in certain neighborhoods, we experience more pressure from people with mental illness and mental problems. And this is due to the high concentration of vulnerable people in those neighborhoods. But it's also partly related to the socialization of care and the decrease of residential mental health services. Recognizing the importance of supporting people in their own environment stimulates the search for more integrated work between mental health care and social organizations, person-tailored and within neighborhoods. Now, in Ghent, we make mental health one of the core priorities of the health department. And we do this together with our partners in the city. And I'm very happy to give this presentation in the companionship of Peter and the people from Psychiatric Centrum Ghent Steven, because they're one of the many partners that we organize our initiatives with. They're our partners in crime. With our initiatives in the city, we focus on 4 core objectives. And one of them is breaking the taboo. There's still a huge taboo around mental problems. As we said, it's only half of the people suffering from mental problems who actually look for help, who find their way to help. So we invest a lot in breaking that taboo. We try to focus on prevention. People who are healthy should stay healthy. So we do that by strengthening resilience. We try to lower the barriers to care. This means we enable citizens to find their way in the complex forest of healthcare. We make sure that it's accessible and affordable. And fourth, but not least, we spend a lot of effort to invest in inclusion of people with mental vulnerabilities. And that's where the story of Peter and Quartermaking also starts. In this, as a city, we aim to work with as many people as possible, so people with moderate to severe mental health difficulties. Now, enough of the theory, let's go to the practice. And let's go from Ghent to New Ghent. New Ghent is a part of town which is mainly characterized by social housing, high-rise buildings. It's built in the late 70s, early 80s. It's about 3,500 people who live in that neighborhood in high-rise apartments. And the vulnerability of those people is much higher than average in Ghent. About 54% of the residents are single, 13% are one-parent families. There's a large number of poorly educated people. The number of unemployed is double as high as average in Ghent. The number of people on welfare is three times as high as people in Ghent. And these economical vulnerabilities also translate in psychological vulnerability. Research showed that 20% of the residents experience moderate to severe mental disorders. Many people struggle with addiction problems, and schizophrenia and psychosis is diagnosed much higher in this region of Ghent. So it's a neighborhood with a lot of challenges for the people who live there, but also for the social workers who work there. Now, in the last 10 years, the neighborhood has became very outdated and run down. The neighborhood is sometimes called a ghetto for people with a higher vulnerability. So in 1917, there were several signals coming from the neighborhood, from organizations working in the neighborhood, about insecurity of people with addiction, people in crisis. So we want to see, like, how can we offer an answer to this? And the conclusion was, like, let's not make this like a negative story about nuisance, but let's turn this into a positive story about inclusion of people. But if we want to do that, we need to invest. We need to invest in meaningful daytime activities for people in the neighborhood, and we need to invest in mental health care expertise, because that was missing. Like, for years, the city invested in community work, street corner workers, but the part that was missing was like the expertise in mental health. So in the last 5 years, the city invested heavily, both in renovating the housing. I have to go one back. Yeah. Renovating the housing and livability in the neighborhood. So in 2018, in collaboration with Poco Loco and Psychiatric Centrum Ghent Steven Gillis, we started up a low threshold drop-in and activity center, the Serre. That's together with a lot of other organizations in the neighborhood. And in addition, a mobile worker also started. And that's what I'll be focusing in the next part of my presentation. The role of the mobile worker was quite unique. The mobile worker is the missing link between street work and psychiatric home care. Now, what's the function of the mobile worker? The mobile worker does case finding and case binding of people under the radar of mental health care. People who don't find their way to the right care, or people who avoid the right care. And we do this by working on the spot. They go on the streets in the neighborhood, they go to the squares, they go into the community centers, they help with food distribution. So they're on the spot, they work there 4 days a week minimum. And that's how we reach our people. We do that together with other organizations in the neighborhood, in collaboration with other organizations, because that's the people who will get us to the right target groups in the neighborhood. And they build bridges. They build bridges so they can make sure that people find the right way, as the shortest way to the right care. On the other hand, they build bridges with the partners on the neighborhood, because for us it's important that people can maintain as long as possible and get the care in their own neighborhood. So by means of inclusion, they offer residents with mental health problems the chance to recover fully and participate in society. They break down the stigma surrounding people with mental health issues. So they create a basis in the neighborhood for people with mental health problems. And by doing this, everybody wins. We have the target group, the individual people that we help, that we offer better care. On the other hand, on the meso level, we have the neighborhood network that we support. The neighborhood network gets an ambassador from mental health care in the neighborhood, so they can address them with all their questions. And on a macro level, everybody in the neighborhood wins, because we really invest in supporting people how to take care of people with mental illness. And I think that's a fourth one I added to this. There's also a win in it for mental health care, because I think the mobile workers are pioneers in neighborhood work. And I'm very happy to be able to do this project together with the four hospitals, the four big hospitals, mental big hospitals, that are active in the vicinity of the city of Ghent. So we learn from each other in this project. Where are we today? We started in New Ghent in 2018. Since 2020, we got 3 extra mobile workers in different districts of the city. The last one started in 2022, and that's with support of financing of caring neighborhoods. Many of the methods like Quartermaking, open dialogue, multilogam, recovery colleges, that's actually the tools that our mobile workers use to go on the street and to help people. And in the meanwhile, the psychiatric home care teams for people with mental problems, they also got extra funding, and I'm happy to see that in Ghent we are looking for ways how to reorganize some parts of their work to also be closer active in those neighborhoods. So we use the blueprint of the mobile workers for that. What are the greatest assets of the mobile workers? I think that's their proximity and accessibility. As I said, like, they work 4 days a week in those neighborhoods. We expect them to be 70% of the time present on the streets, in the community centers, in the building blocks. So that makes that they're very accessible. And it's people with experience and expertise in mental health care. The people who work for us, we got 4 people now. They have all been working in mental health care for longer than 10 years. So they know their way around the system. They can really offer a support in the neighborhoods that was lacking until then. Yeah, they're very accessible. They're contacted a lot with questions. They don't have the magic wand. That's also what they say. Like, many of the situations that are confronted to them are very complex. And they don't have a magic wand to solve everything, because that's sometimes what the other organizations in the neighborhood think. Like, we'll present the question there and it will be solved. We don't have the magic stick, but we will always stand shoulder by shoulder. We will consult people. We will think along. They bring rest into a situation of crisis, and where possible and needed, they build the bridge to specialized help. What are the lessons we learned from this project? I think the co-ownership between the local government, the network mental health care, the hospitals, and the neighborhoods is a very important one in this. And the finances come for a big part from the local government, who invests in this together with the hospitals. it's the local network healthcare who actually organize and supports the mobile workers. So that's where they organize their team. But it's the neighborhoods who actually decides the agenda. So it's like a bottom-up system where the neighborhood actually decides the priorities where their mobile worker should invest in. Also important for me is that the neighborhood approach is a perfect example for implementing Quartermaking, multilogam, open dialogue, so we can use those methods. The mobile workers, they build the bridge. They bridge the gap between mental health services and community work. And they're ambassadors in the two directions. First, it was concluded that they work from mental health care and they go into the neighborhoods. After 5 years of working, we know that it works the other way around too. With all the expertise that they built in the neighborhoods, they can bring that back into mental health care. So, to conclude, this is a story we write together. The city, mental health care, frontline work, civil society, and residents. And together we built the fundamentals for community-based mental health services. Thank you.
Thank you very much, Steven. Any questions for Steven Gillis? Yes, there are some questions in the room.
Thank you for the interesting presentation. I heard that the local government invests in a financial way, but I was wondering if there are other ways they invest besides, you mentioned collaboration, but what does it then exactly mean, collaboration? And second, how did you motivate your board to see that local governments have actually a responsibility in the mental health issues?
Mm-hmm.
Thank you.
The first question is a big part of the funding for this project comes from the city, but the amount of money that we supply is not sufficient to actually pay the workers. Like I also said, like it's people with a lot of experience. So that means like it's not people who come straight from the school benches, so it's quite expensive workers. And the hospitals also co-fund a big part of this. And I think that's how we write this story together. Like we all got a chair on the board and we're able to see how we can build this story together, but also how we can influence each other in that way. And then how could we convince our local government to invest in this? I think Ghent has a quite good tradition in this. And I think there was an opportunity in New Ghent because they started to renovate all the blocks. There was a big budget for building new housing, but also a big budget for social work. And then they looked like, okay, what's the main things we need to invest in? So I don't know what the exact budget is, but it's a lot of money, and a small part of that goes to the community center, to the serre, and to the mobile worker. And that's how we started. After 2 years, we came to the conclusion, like, okay, this is something that really works, and that could work in other neighborhoods too. So that's when we decided, like, let's go and look for extra funding to work in 2 extra neighborhoods. And then with the caring neighborhoods, caring communities, last year, we also saw the opportunity to start it up in a 4th neighborhood.
Okay, thank you.
Thank you very much. Excellent presentation. We are representing Rochdale Borough in Greater Manchester. We have got a similar kind of model where we are utilizing the social prescribing link worker, and they're kind of doing the same sort of model, but they have got some additional, you can say, qualification in terms of having the mental health background. And they're not only dealing with the social determinants, but they're also picking these kind of cases and connecting them with our advanced mental health practitioner that vertically aligns it to the mental health services as well. So that actually reduces the burden on the family physicians and in the system. And in your case, I just wanted to know about the these mobile workers. Is there any formal qualification for them to be appointed, like they had any background as an advanced psychiatric practitioner or something, or was it like a kind of a link worker or care coordinator kind of a role?
Yeah, all the 4 people who work for us at the moment have at least 10 years of experience in mental health care. So they worked in hospitals or in mobile teams or in sheltered housing. So they all have the expertise. That's what I also try to point out, like they bring rest into situations. Often in the last 20 years, no, 30 years, Ghent invested a lot in community work and street corner workers, but it's like you say, they don't have that specific expertise. And with the infusion of those mobile workers, we brought that expertise. And they have the experience, they have the network, they know where to refer to. So I think that's necessary to make this work.
Thank you very much. I think we're going to have to move on to the next.
Yes, there's more questions, but we need to move on to the next speaker. And you actually referred to the help you have from the psychiatric hospital as well. So we're very happy that the head of the psychiatric hospital and the head nurse of the day clinic are now giving their presentation. So it will link perfectly with yours.
You
so
would
we
think there's a
welcome-
strategy behind it.
Probably, yes. So. We welcome Jochen van Steen, who is the director of the psychiatric hospital, and Tine Heip, who is the head nurse of the day clinic of the psychiatric hospital of Sledingen.
That's actually not correct. But so, hello everybody. My name is Tine Heip. I'm coordinator of BW Ipso, sheltered living in Ghent. We are a part of psychiatric hospital Ghent Sledingen. I'm here together with Jochen van Steen. He was previously the coordinator, and now he's the director of the hospital. We will be talking about BW Ipso sheltered living and also our basic values and methodology that we use in our organization. And Jochen will be talking about community and partnership. Yeah. I always forget that I can look here. So BW Ipso, BW Ipso is an entity of Pcgs. We offer 118 places of supported living, going from group homes to apartments that are provided by the organization, as well as guiding people in their own, sometimes social housing. In doing so, the overall goal is to improve the quality of life, of course, but also empowering people to take next steps. So the basic values and methodology, the catchphrase for our organization is that Sheltered Living Ipso offers a safe base by, for, and with people with a psychosocial vulnerability to be allowed to grow from their own personal strengths. This phrase comprises a lot. It's by, so the people have a voice in our organization, they contribute to the organization. If people are not able to do things themselves, we will help them and do things for them, but always we will do it together with them. A safe base to start from and to be able to grow and have a process from their own personal strengths. We will be talking also a little bit about the process from patient to citizen, supportive relational handling or acting, shared decision-making, and continuity in care. Citizenship. Our clients are citizens with hopes, dreams, possibilities, values. We do not disregard the vulnerability, but the goal is always to have the vulnerability have a place in their lives. The goal is to regaining hope, but also a sense of self-worth and value. A lot of our clients have lost this throughout the course of their illness. It's also to have them take a role in society and to find a place where they feel valued, cared for, happy, and comfortable. So from patient to citizen, to human to citizen. We follow the principles of SRA. This is supportive relational handling or acting. It is a methodology that helps us, that allows us to help the client in their recovery and developmental process, and in doing so to create environments that are supportive. The healthcare worker can be a part of this environment, but it is never the goal to make the client dependent solely on the healthcare worker. It is about finding places and people that helps the clients to be as independent as possible. SRA comprises of 3 key aspects: presence-oriented, recovery-oriented, and strengths-oriented. Presence-oriented, inspired by the presence approach, the basic attitude of our professionals is being there for the client. The mental health care worker walks next to the client throughout his or her path. And this path can lead to a lot of different settings. It can be residential healthcare, it can be residential mental health care, community health care, but also jobs, friends, family, and hobbies. It can be everything. The healthcare worker is a case manager who builds and maintains a working relationship. And this working relationship is built on trust. It takes time to build this relationship. The healthcare worker gathers information and will help the clients create a personal plan, to formulate wishes, to make choices, and to set goals. Recovery and strength-oriented care involves healthcare workers working with individuals and their families to reach those goals. Examples of these goals could be for people who are under the influence to become clean, to find a job, to find a meaningful daily life activity. But most of the times it's small things, like taking the bus for people who are suffering from anxiety, or getting up in the morning for people who have depressions. It is finding personal strengths and skills to make life happen. Here on these pictures, you can see clients working in our wood workshop. They renovate furniture for our organization. Also, you can see people knitting fine things. These were flags for the festival that we were organizing to gain funds for our organization. Then lastly, you can see people working in the kitchen for the catering assignments. In this way, they are contributing to our organization, and they also feel valuable. They are valuable, and they are a part of everything that is happening and that we are trying to do. We always use shared decision-making as much as possible. It ensures that individuals are supported to make decisions that are right for them. It's a collaborative process through which a clinician supports a patient to reach a decision or treatment. What the clients know best, and the expertise of the caregiver. The clients know best what is their preferences, their personal circumstances, their goals, their values. The caregiver knows best what are the treatment options, the evidence, and the risk and the benefits. Throughout the path the client takes, the mental health care worker will remain close and available, even if the vulnerability becomes more present. If somebody has to go back to the hospital, it's not like, okay, you're now in the hospital. No, the mental health care worker will come and visit, and they will call if the client wants this. When the resident decides to leave our organization, they can choose to stay and follow up. This means that the contact will be less frequent, but there will still be contact once a month, once every 2 months. It's a way that if something goes wrong, the healthcare worker can upgrade the care if needed. Continuity of care is very important. It's a way to prevent fractions in care, in the care continuum, and it gives a very important opportunity to shift to a more intensive form of care when needed. At this moment, 24 people are in follow-up in our organization, on top of the 118 people that we follow.
Yes, in the last 3 minutes, I will tell something about community and partnership. As Steven told, we are lucky to be in Ghent because a lot of these things we do are in partnership with the city of Ghent and also with other organizations that are here today. What we try to do in the community and in partnership is, in the first place, we don't organize everything that we do in community ourselves. It would be weird as a mental health hospital to organize it for ourselves. We try to support regular community organizations, community support organizations, community care organizations with the experiences that we have to make possible that all our people living in the sheltered housing projects or in other projects can gain that accessibility in regular, common things that the city and other partners organize in the community. That's the first thing. Then we have in-betweens. One of the very nice in-betweens that you can, how does that? The green button, okay. One of the very nice things that we have is you have a community services organization in one of the neighborhoods where people from the sheltered housing project live. We don't have an own place anymore for the people, the staff to come together, etc. We asked the organization in the neighborhood, can we join in your organization? Can we use some of the communities? And can we organize the community center together? And now that has been for that in a couple of years. So there we do it together. We co-create with the organizations in the community. And some of the projects that we have in the community for leisure, for activities, we organize ourselves. So it's always the three things that we have. And for some people, the first step to go to a regular organization is not that easy. So they start in the organizations that we create ourselves. We have a very big farm that you see just outside of Ghent. We have Pocolocco, what Steven told about, some places in the neighborhoods of Ghent. Other partners like Caris, who is here today, organize in another area in Ghent, the same places. So there's an easy accessibility for people with mental health problems in the community to be part of a community. And that's what we try to do. A lot of people with severe mental health problems aren't part of a family sometimes anymore, aren't part of a community anymore. They don't know their neighbors, they don't know the area where they live in, and we try to gain accessibility in their own environment. Always in these projects in co-creation. Tine told a lot about what we do in the sheltered housing project, but in all the projects we do, we try to co-create. And that's also where family and friends come in, because if you can make it possible that people don't see themselves anymore as a patient or a client, but that they can see themselves again in their strength as an artist, as a bartender, as someone who picks up the phone, who directs people to the direct places in the organizations, we always try to co-create. Even we have someone who does a lot of administration for the organization. She is somebody with lived experience, somebody with a psychosocial vulnerability, and we try to do that in all the organizations. And some examples you can find in the presentation that we have made. We're also a partner in a lot of things, and the partnership is not always organizing ourselves, but is supporting from the experience that we got to make possible that the organizations also are accessible for people with mental health problems. It's also about continuity of care. A lot of care is fragmented right now, so by organizing parts ourselves, by co-creating with our organizations, and by making it possible that everything is accessible, we try to keep the accessibility integrated, because people have the possibility to access everywhere in their own environment, and so we also have a partnership in a lot of organizations and things that we make happen. The living part, Tine told about, leisure and encounter, a lot of places in the city of Ghent where people can come, have a coffee, do activities, or have a step up to other things that they want to do. Some workplaces, Tine also told about, where people can come to work again, where they also can have a trajectory to, again, a paid work if they want to do that. We are also involved in recovery colleges, and we try to do a lot of care innovation. We have a Respijtwoning, but I don't know how you translate it in English. It's a place on the farm where people can come for a maximum of 5 weekdays. When they feel it's not going okay at home, I have trouble with my neighbors, I just have to get out of it for a couple of days. I don't need to go to a ward, I don't need to go to a hospital, but you can be on the farm in a very nice, it's a tiny house, in a very nice tiny house. You can be there for 5 days. There's activities from 8 in the morning till 8 at night. There's someone, you can have dinner there if you want to, you don't have to, but you can be there for a couple of days and then go back to your own environment. And we see that a lot of people use it, a lot of people come over and they have a very good feeling when they're leaving, and they can encounter again what is at home. Conclusion, I told about it, a lot of it has been fragmented. We try to, by not organizing everything alone, but creating a lot of partnerships to create a continuity of care, patient-centered, like Tine told, with maximum of ownership, always in co-creation, and trying to make it possible that people can be in those new social roles. And we try to have a lot of collaborative partnerships, like we heard about also in the previous presentations, to make that happen. Thank you.
Thank you very much. There is one question in the app. There's 1 minute, so I'm going to take that question and perhaps one other question in the audience if there's a burning one. And I found it really interesting because they're asking about the role of the informal caregivers, so family and friends. I think in everything you've explained, they play a role, but the question is as well, is there any support available for informal caregivers? Do you help them with workshops, training, financial support? So for people, family and friends, informal caregivers?
Yes, we do. We always ask the people, of course the clients have to give permission, but if the family or friends have questions, they can always come to us. We also have a partnership with Similes where we organize evenings for family and friends, and we also try to always call family and friends. We also have family days that we organize, so to bring them to us to meet each other. So we try really to give them also a place in the society. Also, sometimes they are volunteering for some activities, or if we do study days, then they are also invited. We have a newsletter in which we say what activities that we do. Family and friends can be invited to that as well. So,
all right, a lot of activities you
yes,
organize
we do
yourself
a lot.
and with the resources in the
Yes.
community. Thank you very much. Any other burning question? Yes, at the back. One more question, and then we go to the next speaker.
Hi there. Okay. Thank you. It sounds like your organization really helps patient in a holistic manner. I'm wondering about your intake process in terms of, do you have a step care model or pathway or flowchart to kind of manage the resources in a timely and effective manner? And I'm also wondering if there's been any work about reaching out to people who might, not reach out to the organization themselves and who might be falling through the cracks.
So the first question, we have an intake procedure. If people want information about our organization, every 3 months we have an info session in which they are invited to come. It's free. It's for caregivers and it's for family, friends, or people who are interested to come to us. If they say, okay, I want your carer support, then they have to fill in some forms, and then they have one meeting with somebody of the organization. We have a central place where, because we have 2 teams, where together with the psychiatrist we will evaluate the question. Rarely we say no, but this makes also that we have waiting lists.
But that's for the sheltered housing part. But everything we told about the projects in the community, there people can access always. There's no intake or nothing over there.
All right, thank you very much. Now we go to Carolien Schalenbourg. Yes, thank you. Carolien Schalenbourg, she's a researcher at the University College Leuven Limburg, and she's going to talk to us about open dialogue. Can it be implemented in our care context as a response to crisis for people with psychiatric problems in the community?
Okay, thank you. I'm Carolien. I'm from the University College Leuven Limburg, so it's lying on the X between Leuven and Limburg. Our campuses are there, and also we have 8 expertise center for research, and the center I'm working from is Health Innovation. Also very important on this first slide is the partners we're working with. Dag van Wetter, also here in the room, works for Vzw, but he's open dialogue companion and expert. Also, Professor Stijn van Hullen, associate with the University of Ghent, is partner in our project. And the other 3 logos you can see is from our region on the other side of Flanders, not from here, next to Antwerp, but are the mobile or the psychiatric services for mobile teams and also psychiatric hospitals, and it's Nolim, Reeling, and Ghent. And the teams that are also participating in the research project are from that organization networks. Okay, this works. I'm not the only one doing research. I have a team and it's very very nice and inspiring to go through this process of also open dialogue, but going with the teams. We call them also our ambassadors. So I'm not doing this alone, so also credits to my companions in this. But I'm going to briefly talk about what are we doing there in Limburg. So it's a 2-year research project, and our main question we were asking was how can we, I'll look there, provide a better response to crisis for people with psychiatric problems in the community in the region of Flanders, and we specified Limburg. And the main thing we wanted to see, how can open dialogue be interesting in that, and also how can that be implemented? That was our first goal. So I'm going to start with why are we doing that? Why am I starting with that? How does that topic leads to us? What is, very shortly, open dialogue? And then tell you something about the research process and the co-creation process and initial findings. Okay. Why? I think it's very important, even if some people heard maybe yesterday the presentation of Doug. Why do we want to change something? And as we do research at the university college, it's always practice-based research. So we get a question from people from the practice, and they came to me like, "Oh, can we do something about that? Because it's really promising, convincing figures, and we really want to do something about it." And we also have the pioneers in Northwest Flanders who had inspiring conference days. But it's also a reason because lots of research, one of the psychologists said to me, people with psychosis and double diagnosis are excluded. So we really find it interesting to do something that includes them, that it's not for everyone. And I also have my own experience working in mental health hospital on a ward for admission for people with psychosis, where we had a lot of admissions or forced admissions, more than 80%. And from that experience, also wondering how can we maybe change that? How can we do it differently? How can we do that? So maybe question to the room, who has already heard from open dialogue? To have an idea. Okay. Lots of people, because I'm not going to explain it. I can't do that in 10 minutes. That's not possible. Maybe Doug can, but I can't. But just some definition to have an idea what I'm talking about, and what the teams were very interesting in our region to get into, already had some knowledge about it. And but it's a system originated from Finland, but built on existing things like family therapy, needs treatment, but with 2 essential ingredients. It has a more therapeutic philosophical approach, a way of being, we call it, and more organizational principles. I'll show you a picture in a moment from the principles. But the main thing, the center of is coming together in a network meeting and bringing the person of concern together with the persons of his social network. Don't see it too big like everyone, but we're bringing them together with 2 facilitators. And those 2 facilitators are having the job or the goal maybe to create a safe space where we can speak, where we can talk in such a way that the next time of speaking is possible. So the focus lies on the process. So here you see the 7 principles, divided in more organizational and more the way of being, the heart, I say, of open dialogue. And you also see on the bottom a picture of 2 teams in our region visualized the principles, also to explain it more to their team. And it was in also some accreditation of Plane Tree. They had to say, what are you doing? And they visualized, and it helps they made an old poster of it, but it really helps to tell or explain what is it about. So, getting into research project, watching my time, very short. It's a participatory action research, and maybe some timeline is necessary, Before we started, very important, because there was this interest of doing this, we had introduction sessions from 4 hours about, what's open dialogue? Do we understand the same? What is it? The 7 principles. Afterwards, with the teams who were interested to go further on it, we did SWOT analysis to see at that moment how are we already having some similarities, or what are still the obstacles, or what are the challenges. And then 5 teams decided, okay, we want to get in. So we were very happy because it were 3 outpatient teams, a crisis team, a recovery team, and a team for early detection of an intervention of psychosis, and 2 residential teams for psychosis. One of the main, I didn't put all the research questions, is that we use a framework, and it's called, I'll show a picture, Consolidated Framework for Implementation Research. We did a focus group at the beginning, and then we're doing now the focus group. So we're not yet finished, but we have already some results. And in the middle, we did the 6 co-creation sessions and also some interviews. So we wanted to identify what factors contribute, what is it that teams, or what defines that they get further with open dialogue or that holds them back, because we are very interested to see that. So this is the framework, not going to explain it, but might be recognizable for someone. But we're looking at this different, like other setting is like how is the organization with other organizations or the teams connecting on that way, but also the intervention itself, open dialogue, how is it flexible to change or to adapt, or what are individual characteristics. So a lot to take care of and to analyze. To give you some input, these are the ones who drive us forward, the ambassadors, we call them. So we set up that we had at least 2 persons by each team taking, engaging with the co-creation process. 6 times we came together. But if you see, there are more people, so there were more people from some teams that were engaging and getting time to making the process with us. You see some teams, but very important is we searched as researchers also our way in how can we do this as dialogical as possible. And every time, one of the questions at the end was also, what should we discuss next time? What's important for you to go into? And then we had some exercises, we had thinking, we had reading. And at the end, we asked them to have a script about how they're working with, at that moment in the process with open dialogue. Watching my time, this is one important slide. I will say some things about it. What are already things that are lifting up, because there are many things, they're not in a specific way, but speaking about development instead of implementation. You can talk about implementation if you say, oh, we have this e-learning. It's maybe not a good comparison, but we want to implement it. But really, from the start on, we felt like, oh no, open dialogue, it's complex, but it's like, how do we develop it in our practice? And that's also interesting that we're trying to, with our research and with the focus group, get the story of every team. And the most interesting thing is that every team has a different speed and a different way, and also, lucky for us, some obstacles, but we can learn from that, and we hope that other regions can learn from that. We feel that we can be proud of ourselves. Sometimes there's Limburg as our region power, because there are 5 teams involved. That's not whole Limburg, but it's significant. And they had the 6 co-creation sessions, and they also said, we want to do this further. So they said, we're going to sit together, and we're just organizing now every moment to put it on further. Well, a big challenge in our experience now is involving peer workers, because it's a little bit strange, because inherent at open dialogue, it's very open for peer workers, but we also had 3 teams. There wasn't a peer worker at that moment, so then it's also difficult to involve them. And the other main challenge is time. If they have just a little time to do some sessions or to them, it's not easy to involve them also in this research. It's something we want to hold on to and get further with. I'm looking at my time. Can I still have a minute? No? 1 minute, okay. So I can go further on this, but I had some quotes, and I think that's something, it's very important to have some little successes. So the feedback from trying, when the teams were trying, how can we do this? How can we set those little bit steps? And for me, I'm going to the last thing. This is a picture that gives the full thing of going in this process and implementing. The boats are standing for me like everyone is like going a different direction, and our organizations are like bigger and some are with lots of speed. But look at where your own boat is going and start with that steps and start the conversation in the moment you can, and that will help you go further. Thank you.
Thank you. There is one question from the audience, which is in the app, so I'm going to give priority to that question. And it says, somebody asks, what after the 2-year project, what about sustainability of what you are doing now?
Yeah, that's very important. We're trying to get the one of the next big steps, because we did co-creation, but not equal to the foundation training, and further training is really necessary. So we're now also lobbying, and yeah, it's not that easy, but we have a good feeling that there will come further training, and also they because it's so beautifully bottom up, the teams are really taking the arm of their managers and saying, we really need some space or to create it further and develop it further.
Right.
So we're trying this.
Thank you. Now we welcome Nikki van de Ginsten. She is from the health fund called CM in Belgium, and she is going to talk to us about mental health in all policies, not just health in all policies, but mental health in all policies.
Yes, okay, thank you. I'm here to give a plea for mental health in all policies, which I believe is preaching to the choir, I hope, in this room. I'm from the CM, which is a public health insurance fund, so we have lots of contacts with our members. And from that perspective, we like to look at what are the needs of our members to give them their full possibility of achieving their greatest life quality. I'm going to give you some examples and some research to make my case for this mental health in all policies and bring you on a journey to my conclusion. The button is this one? Yes. As we all might have lived and experienced during the COVID-19 pandemic, we already heard a little about it in the plenary session, is the COVID-19 pandemic showed us how lots of different aspects of life have an impact on our health, and by extension, also our mental health and our well-being. My organization did a study, a qualitative study, interviews with workers in the health sector, in the social sector, or the education sector, on how the pandemic took down protective factors in children and young people in Belgium. They found that due to the saturation of the health system, a lack of social contacts and interactions, closing schools, family context that was altered because people had to work from home, because people lived more closer towards each other. When you have, for example, 8 people in a family and you have to stay all inside, that has an impact on the way you live and how you experience your day-to-day life. Also, their recreation, their hobbies were limited, and also there was a lack of perspective for many people. Nobody knew when the pandemic would simmer down, when it would finally end. It hasn't. Well, officially it has, but COVID is still with us. And that had a big impact on the mental health of children and young people, which is a sign on the wall that we should take into account when taking these measures. What impact it has on mental health. So these interventions in personal freedom had their impact on interconnectedness of life with mental health policy. And there were social, economic, and environmental factors that influence mental health, which is true in the broader context of life. Social, economic, and environmental factors have an impact on mental health. So we need a holistic approach. Another coworker of mine, Svetlana Sholokova, from our study department, did a study on the prevention in mental health and how that is best acquired. As you see here, mental health is an iceberg, and we all see the tip of the iceberg. Mental health care, as we see it in a very narrow sense, hospitalizations, consultations, rehabilitation, prevention, mental health promotion, the classic how we look at mental health policy. But beneath that iceberg, that's the classic view of an iceberg, you have several layers of other policy areas that impact mental health. First of all, education, how you talk in school about mental health, but also how that education is given, more on that later. Social service, we had some great examples of housing earlier. Employment, how we experience our work. Burnout is a common problem in our society. Culture, environment, asylum and migration, the battle against discrimination, and sports. I could talk on all these subjects a lot, but I know I only have 10 minutes, so I'm going to let you imagine a bit how these can be applied. In 2019, so before the pandemic, I did a survey among students in Ghent. I know you've heard a lot about Ghent today, but also I was a student in Ghent. And I did a study in more than 4,000 students, and I asked them about their mental health. Among others, I posed this question. The question is at the bottom, it's in Dutch, and it says, the current study pressure has a negative effect on my mental well-being, from totally disagree to totally agree. And you see in this graph that self-reported, these students very much agree that the study pressure has an impact on their mental health. Yeah, on 62.6%, they said it had a negative effect on their mental well-being. This was in 2019, before the pandemic. So I posed the problem: how do we approach this challenge that all these different policy areas have an impact on our mental health? We can start with that tip of the iceberg: increased accessibility, a larger availability, and prevention. But amongst prevention measures, there is mental health in all policies. We need a high-quality integrated mental health care and a general policy of integrated care that addresses mental health as part of the larger health system, so we can fortify the resilience of our population. An example of how we can address this is a project called the Community Health Workers. There are community health workers active now since 2020 as part of a federalist intermutualist project in Belgium, which means it's a project from different public health insurance funds in Belgium. My organization, Solidaris, Helan, LM, these are different public health insurance funds in Belgium. And these community health workers can build bridges between individuals, communities, and health and welfare professionals on a very local level. They're active in Ghent as well, but also in Tienen, Ostende, Namur, and I think Liège as well. And they provide support to navigate in the health system, because that can be a big challenge for people, and provide concrete solutions to overcome their difficulties in finding healthcare, but also having very simple questions about their health. 7.6% of care-related actions led to contact with a psychologist for these people in these neighborhoods. These community health workers are people in the community. For example, this person is a community health worker in Ghent. Her name is Nikat Sereke, and she is from Eritrean origin. And she has this quote: "As a community health worker, I can clarify to the doctor, don't you think it could be stress because this mother came here through Libya, the Sahara Desert?" So she comes into contact with people from other people from Eritrean descent, and she can relate to those problems. And she can talk to the doctor and mediate and say, she's probably been through a lot. This could be a backache. Yes, you can write paracetamol for it, but if you address this stress, if you address this trauma, we can get to the root of that problem and help her with physical therapy, psychology, etc. Not saying you shouldn't give paracetamol at all. Should give both when people have pain complaints, but the root of the problem. Nick had also set up a project called Ghent with a set of other partners, and they did a series of sessions on trauma, migration, resilience, and mental well-being amongst refugees. This was in Tigrinya and Dutch. Tigrinya is the native language of a lot of Eritrean people. And this is supported by community health workers. As a last example of how we can address mental health in all policies, we have this very concrete example of community health workers that are already active today. But say we would be improving daycare. You think as daycare as just a place you drop your child off and then you go to work. But if you have quality daycare for your young child, you have better care in the first years of our children's lives, which is a prevention of mental health problems later in life. And it also means that there is a better work-life balance for parents. They can go with, I was going to say in Dutch, with a gerust hart, with a good feeling to work and know that their child is safe and don't have the pressure of combining work and family and all these things, and you have burnout prevention. And as we all know, happy parent means happy child. Not necessary, but it contributes a lot. Making sure that these parents can live their life well and care for their children well has a lot of prevention for the mental health of both the children and the parents. So my conclusion brings it. I gave you the problem, which we also saw during the COVID-19 pandemic, clear in our own day-to-day lives. And I wanted to make a plea for mental health in all policies. I really think that no matter what policy area you work in, this could be the justice system, this could be mobility, this could be housing, you could think to yourself, how does my policy area affect mental health? And maybe one of those examples that I gave, you think, how could that be? But maybe the day-to-day commute to work on the train is very stressful for a lot of people. And our train company is now experimenting with silent areas on trains, which could reduce the stress on your day-to-day commute. That's an example of how any policy area can have a positive effect or a negative effect on mental health as a whole. So we need to have a need for high-quality integrated mental health care. So I can
Thank you very much also for the concrete examples. Any questions from the room? Because you're perfectly in time, so there's still room for 2 questions. Mental health in all policies?
I guess all was clear.
Everything was very clear apparently, yes.
Sorry,
and also
can I just
the virtual audience.
You say you're from an insurance organization?
Yes, in Belgium we have a very original system in which the insurances are provided not by private companies, not entirely by the government, but by organizations that stand between the public health insurance funds. We get our funding from the tax money of people that comes through the RISIF, our social security system, and we provide them with insurance, but not just insurance. We also do things like the community health workers and having contact with our members and supporting them when they have questions about their mental health care, but also their health care. Yeah, more on that this afternoon. I'm giving another presentation.
Beautiful, thank you.
Okay. All right, thank you. What time is your presentation this afternoon?
4:30, it's in the funding session.
All right, and another question from the room?
Yeah, hello. I really applaud that approach. But a number of organisations, a number of groups are very self-protective of their territory and don't give up their space easily. You know, for example, maybe diabetes or cancer or How would you go about sort of convincing them or persuading them to include mental health in their in policies in areas such as that, where you know the stakeholders are quite protective of their space traditionally and quite conservative as well sometimes?
It's a very concrete question and a challenging one, for which I thank you. I do believe there's a lot of what we call care paths in Belgium, amongst other things, for diabetes, in which they want to improve integrated care for these groups. And mental health care is an aspect in this. And I think if you look at the research, then they too can see that this is a huge asset for how these patients experience their health and their quality of life. And we're really trying to make a plea here that we don't just want to keep people alive, we want them to live and enjoy their lives. So just the research and pressing on that matter. Okay, thank you.
All right, thank you. And now we're going to Norway, because Lars Poverund is going to tell us about integrated assertive outreach in Norway.
Hi there. I'm not supposed to be here on this stage, but Tor Helge, who was going to do this presentation, he had to stay at home to work on his PhD. He got very strong messages from above. So then this is going to be kind of improvised. Does this mean I have only 13 minutes? Yeah. Does everyone know what FACT team is? Yeah, that's good. If you don't feel embarrassed. It's a way of working with very sick patients, but at the places where the patient wants to meet. Very short. I'm a user. I'm a patient. I'm not a patient now, but I'm a user of both mental health services and addiction services. And I'm here as a co-researcher. We are 3 co-researchers with user experience in the PhD project. And I'm also a user representative on a hospital in Oslo with responsibility for giving advice to clinics for addiction and mental health. Very interesting and very exciting, and we are listened to. So user involvement in Norway is very good in hospitals, not so good in municipalities, which is sad. I'm working on it. The first assertive community treatment in Norway was established in 2007. They are on the decline. They are being replaced by flexible assertive community treatment, or FACT. The first one was in 2013, and I was a user representative in the planning of that, which was an interesting experience. Mostly very okay. At one time, not so okay, because we started talking about people with personality disorders, and the people there started kind of laughing, because sometimes we have a tendency to stigmatize our own patients. Personality disorders are so difficult, and oh wow, we can't do those. And people started laughing, and I got really mad, and then they stopped laughing. There in Oslo, where I come from, there are 12 municipalities, and there's a political. Every municipality have to have at least one FACT team, and it's growing. We're now getting the FACT team originally is about psychosis, but we are now getting specialized FACT teams for example, addiction, and we're getting special FACT teams for young people or children, but mostly young people, youth, and we're getting FACT teams for the elderly people, which I think is a great idea, because when you pass 65 years, it's 2 years for me, no, 1 year almost, you're supposed to be old. You're in geriatric care then. And I don't understand it, because people don't get old the same way they did before. We're young till we die almost in these days. We're also, thank God, there's talk about getting FACT teams for people with personality disorders and bipolar disease. So things are happening, and I like that. I love the idea of FACT. In Norway now, there's about 100 teams, and they're getting more because the government is very, they want more of those. It's a collaboration with specialist healthcare and primary healthcare, half and half. So it's financed both by the hospital and the municipality or city in our case. The PhD I'm co-researcher on is about FACT teams, and it's about innovation in FACT teams. It's very interesting and kind of hard to be part of it. But I recommend, in Norway you don't get money if you don't have people with user experience in the project. You don't get it. So some people then just get a user to sign something and then nothing more. But I think that'll stop, because I think the people giving money is now getting very aware of that. And I hate it when they say it's user participation, but it really isn't. It's just a nice emblem. I have user participation. I've had one meeting with them. No, I have. I don't use that. But I have a movie. I have a little film, and it takes about 6 minutes. So we should probably stop there. And I'm sorry it was kind of all over the place, but I haven't had very much time to prepare, and I haven't prepared this myself, and so I had to use his papers. So that's it from me. No, but it's. No, I don't have slides, because if I had slides, I'd use them. I'm sorry. No, I think that during a conference like this, you see thousands of slides. And I think sometimes it's good to rest the eyes and just listen. Because, yeah, there are too many slides, in my opinion. So I have this film, and thank you for
6 years ago, we had the 3rd European Congress on Assertive Outreach in Oslo in 2015. And since that time, there have been further developments of the community-based mental health services in Norway, both in primary care and in the specialized mental health services. While most of the patients seen by the community mental health centers are seen in outpatient clinics, the largest increase during the last years have been in mobile teams. And among these, we find the crisis resolution teams, early interventions teams, and rehabilitation teams for people with psychosis. And the largest group of these teams now are FACT teams that are developed during the last years.
We have about 70 FACT teams and 8 ACT teams in Norway. In recent years, we have established FACT teams for elderly, for persons with substance use disorders. We have forensic FACT teams, and at the moment, the health authorities are piloting FACT for young people. FACT teams in Norway are organized as a binding collaboration between district psychiatric centers and municipalities. Results from the research-based evaluation of the 7 first FACT teams showed improvements with regard to quality of life, with regard to meaningful daily activities, financial situation, the living situation with less homelessness, with everyday practical and social functioning, and symptom reduction with regard to anxiety and depressive symptoms, and also severity of alcohol use.
Jeg har fått veldig god hjelp av FACT-team fra å være mest sengeliggende, ikke ha noe særlig livskvalitet, overmedisinert. Jeg var veldig stresset, hadde mye uro. Sakte, men sikkert, med samtaler, har jeg fått livskvalitet tilbake. Og nå har jeg et helt annet liv. Jeg står opp om morgenen, jeg har mange aktiviteter. Jeg føler mestring, livsmestring. Jeg har til og med giftet meg. Det har vært en prosess da, som har gått over flere år. Men jeg må si jeg er kjempetakknemlig. Jeg har det veldig bra i dag.
Jeg føler meg beæret som får lov å bli med på den reisen deres. Og se at de opplever selv hverdagen sin bedre.
The main bulk of community mental health services in Norway are situated in each of the 365 municipalities we have. They focus on housing, economy, meaningful activities like individual job programs like individual placement and support. They focus on social inclusion, often in cooperation with the voluntary sector, and also specific treatment programs. This is not exclusively something for the specialist services. They also have intensive collaboration with the GPs, in particular concerning somatic health, which has come to greater awareness in the recent years.
Det den opplevelsen av å bli invitert inn i livet til brukerne, og få lov å være med på deres reise, og være med på deres prosess mot å skape endring i livet. Det å se at de opplever mestring, og det å være vitne til hvor lite som egentlig skal til.
Deltagelse på alle livets arenaer er sentralt for menneskers psykiske helse, og det å stå utenfor skole, arbeid og samfunnsliv er en dårlig forutsetning for god helse. Det er godt folkehelsearbeid å gi mennesker en mulighet til å stå i arbeidslivet. Vi må tære å tenke utenfor boksen. Vi må være tilgjengelig og tilpasningsdyktig for å finne metoder slik at vi når alle dem som sliter.
There is still friction between the specialist services and the municipalities on at least 3 topics. One is, who are the experts? Secondly, what should be the focus on the services? And thirdly, to move resources and focus in the specialist services from inpatient treatment and outpatient clinics to joint outreach services in collaboration with the municipalities.
There is a growth in patient-centered care in both hospitals and other health services, and there is also an increasing awareness of involvement of family members, including children of patients. Other wishes are to have more patient-centered mental health care, which includes having emphasis on shared decision-making and more emphasis on personal recovery. Easier access to the mental health services is still needed, but it's equally important to have good enough time, both in intensity and duration, to develop trust and a relationship between the service user and the service provider, so that this can lead to a better life for the service user.
Thank you very much. I was thinking we were going to another country, but actually I see a lot of things that you have been doing in your country also reflected in what we've heard before. Community work, health in all policies, mental health in all policies, building bridges between residential care and ambulatory care. Are there any questions from the public for Lars? I think it's also very strong that you as a patient, as an experienced person from healthcare, are actually standing here in the place of a researcher, and that in Norway research cannot not take place if they don't involve patients. That's really strong.
I just need to say I'm not only a user, I'm a nurse, I'm a drama teacher, and I'm a poet, and I'm a human being. So I had to say that.
Thank you very much. I think we can conclude on that and all go for lunch. Thank you very much.
Thank you very much, everybody.